Instant right superficial femoral artery occlusion. This is a case of 75 years old male with HBP and who is a former smoker. In his medical history, we can find an ischemic heart disease with triple coronary bypass, and lower limb artery disease with angioplasties, on the left SFA and the CFA, on the right SFA. His clinical symptom is an intermittent glycation stage 2B. The biological parameters are normals. His treatment is aspirin, clopidogrel, atenolol, telmisartan, and rosuvastatin. On the arteriography, we can see stenosis on the CFA and bilateral occlusion of the SFA in stent. First, we have already treated the left side with an angioplasty with balloon on the left common femoral artery and an angioplasty with Eluvia stent on the left superficial femoral artery. This procedure will begin with right antegrade femoral access and terminal angioplasty, and then laser angioplasty or DCB or DES. With this case, we will discuss access sites, we will learn management of intrastent restenosis, and we'll discuss of respective roles of laser, DEB, and DES.
So we are going to place now the introducer, and I let you work after. You have chosen a 6F Terumo introducer. Voila, I think it's safe. So we have several dots like pearls of calcification. On y va. We have one. The first one. Okay.
No thrombus.
No.
As you were seeing before, it is disease.
It's a subtotal occlusion only.
It's subtotal, huh?
It's simply a short subtotal occlusion here.
With a global angiography, it was considered as occluded.
Yeah.
So it shows the power of antegrade injection.
Selective angio. Yeah.
Could we see downflow?
It is also a balloon expandable stent in the middle. Yeah.
But he has a history of a very old.
Yeah. It looks good. Yeah.
It confirms what we said before, that balloon expandable stent works in SFA, and they are short. It's okay, huh?
Yeah.
Perfect.
Okay.
Stent.
I think it's possible with a 0.18 guide wire, this one.
It should be, yeah.
The balloon expandable stent was not so bad. I mean, it was an old one.
It's a little bit small as compared to the dimension of the 19 stent.
Right.
So it's probably a little bit undersized. So we have two stent lesions, one inside the 19 stent, and then one affecting the short balloon expandable stent.
Would you consider doing a drug-eluting balloon in the second lesion?
In my practice, I would treat the entire SFA with DEB. We can discuss whether we should limit dilatation here focally to the in-stent restenosis in the middle of the stent. And then we can also start treatment at the level of the distal end of the balloon expandable stent upstream to the side branch of the SFA. So that would be my strategy. I wouldn't touch the segment in between. This is okay.
I agree. I will not touch it.
Yeah.
So, okay, so I'll give you a 0.18. What will be your choice or guide wire?
Advantage 18 Terumo. That would be great.
Yeah, it's the most difficult part.
Yeah.
So it's okay. There is
you
probably
need some support.
Yeah.
Okay, we give you a balloon. So we take a 5mm balloon, coaxial. It's an old balloon expandable stent, Palmas, that has been placed several years ago in a calcified territory, but we see that well. I'm touching the foot pedal.
Okay. Okay, here we are.
Yeah.
Yeah.
You can take the...
Yeah,
Yeah,
you are,
yeah, yeah.
you are across. There's a lot of resistance. So
Voila.
that's
Okay.
So here we are inside the.
Yeah. it's already
That's okay. That's okay. We don't need to move further down.
Okay,
It was in the middle of the stent. No,
Stent,
the
yeah, more
instant
distal, yeah.
restenosis.
here.
Inside, further down, just in the middle of this. Okay,
Yeah,
here. Yeah.
It's transition
Yeah.
zone.
It's 5 millimeter by 4 centimeter.
Yeah, that's okay. Stenosis.
There you go.
Yeah.
Very short,
It's a focal
very focal, huh?
resistant
This-
lesion here. Oops, 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 oops. It looks like as if the stent is a little bit not in between.
Here, it is diseased here.
Yeah,
More
but it
proximal.
was not relevant. Yeah.
12, 13, 14. Because you see, we had a lesion above, huh?
Yes, of course. But we will stand it anyhow.
It's
So
all diseased.
yeah.
But you don't prepare the lesion? You don't want
Usually
to...
I don't do it, but you can do it, of course.
Okay,
Yeah.
Wow.
Okay.
It is not bad, huh? It's
Yeah.
already a good result.
So 6 millimeter Eluvia.
Yes, by 150,
Yeah.
the maximum.
Yeah.
Because I want to know precisely where we are going to place that drug eluting stent. Okay. So we have taken a 6 millimeter.
Yeah. And we should also use a 6 millimeter Ranger balloon.
Yeah.
Here it is.
Okay.
You will do it here?
Yeah.
Or a little bit? Could you please?
So it's very precise.
Yes.
There's not a lot of movement of the distal segment of the stent.
We will need another
Yeah.
another
Oops.
stent.
it's
Yeah,
something.
that's
Okay.
that's
Right at the
a
lesion.
stenosis.
Yeah.
Okay.
That's the
Yeah,
the
yeah,
severe
yeah, yeah.
stenosis over here. So 4 centimeter additional
Okay.
stent.
We
What
are
was the
going
length of this?
150.
Okay.
10. It's 5 millimeter by 4,
Yeah.
40, 15,
Tac.
20,
Yeah.
20. Deflate. 16. We have a short balloon. It's the same balloon that we are using than before. So we have dilated and impacted all the stents with a 5 millimeter balloon at a pressure between 16 to 20 bars. We are waiting for the deflation of the balloon.
Fantastic.
Voila.
Perfect.
Just
So-
recently, the Pacuba study is published electronically in Czech cardiovascular interventions, and they use the Eurocore balloon, which is a non-effective drug-eluting balloon. And they compared to plain balloon. They had 13% patency of instant restenosis treatment with plain balloon, and 34% with the drug-coated balloon, so-called drug-eluting balloon.
So good.
Yeah.
40% after
30
1 year?
34 with the DCB and 13 with plain balloon. So this is not sufficient for.
We have a
Copper only.
we have a 60 or 100 centimeter
Then let's
Ranger
take
balloon.
100.
100.
So we take 100.
Yeah.
Yeah.
6 by 100.
So we have taken a 100 centimeter
Yeah.
Ranger balloon, drug coated balloon. So it comes with a cover that we are going to extract in order to protect the coating.
Yeah.
We have a timer here, 4 seconds.
Yeah. So I inflate usually a DB for 3 minutes.
D'accord? Yep, enough.
The balloon expandable stent looks already much better
Dilated,
than
yeah,
before.
yeah.
Yeah.
It's the same balloon that is used.
Yeah.
We may have to place another stent at the proximal part. We'll see. We'll see. I hope not. C'est bien. C'est fait.
Usually the Eluvia stent design should guarantee
Oui.
a good opening of the edge
Yes,
because
we-
there it's closed
It's
cell.
closed cell.
It's cross cell
Yeah.
stent.
Looks good.
Perfect.
not bad, huh?
Perfect.
I will try to have an image without any guide wire. Yeah. It's nice result. It's okay. I think we can compress. Huh?
It's not simply okay, it's perfect.
Yeah. Yeah.
C'est bon. Thank you, gentlemen.
Thank you. That was excellent.
Gentlemen, we are here to comment the case that we did just a few minutes ago. Thomas, could you comment on the images that we see in this patient?
Well, basically, we had some angiographic baseline information from a non-selective angiogram, and this was suspicious for a short occlusion of the distal SFA. In fact, what we see now, having an antegrade stick, is a severely calcified SFA. Then we have a subtotally occluded stent in the middle part of the SFA, so it's not a complete occlusion. There seems to be a small channel, and then we have a short segment without a stent, which is diseased in fact, but not severely stenotic, and a short in-stent restenosis at the distal segment of the SFA.
As you said before, I mean, it was a balloon expandable stent that has been placed several years.
Yeah,
before.
and it seems to be a little bit under-expanded.
Exactly.
So,
As it was 20 years ago. We were under-expanding.
yeah, we had been more careful.
We have been more careful. So the discussion was can all drug-eluting balloon or...
Yeah, this is a little bit the strategy that we use nowadays in our service. It's we are preparing the vessel as we discussed already, and if we notice that the lesion and the patient is an angioplasty responder, so we try to continue, although the vessel is quite calcified, and you can have questions in terms of the efficacy of only drug coat balloon only therapy in these kind of calcified, heavily calcified vessels.
So we followed Thomas with a 5 mm and 4 cm balloon, and we did sequential dilatation. Everything was performed over 0.18 guide wire from Terumo. You cross beautifully that lesion, and here is the sequence of inflation all along.
So it was a very rigid in-stent restenosis, typical for near-intima hyperproliferation. Yeah.
So we had that image, finally, and this was the time where you question again, drug-eluting balloon alone or stenting. So we decided anyway, after discussion, to stent, and the discussion was, do we stent from this area, I mean exactly at the position of a stent, or do we respect this zone? And Thomas, we defended to respect this zone.
Yeah, because the reason was that this area was not severely diseased initially, so it does not really need a scaffolding, so stent is not really indicated, and the more severely calcified area is proximal to the short stent, so we have bilateral calcium, and the decision was made to include the old stent into the stent area where we can implant one single 15 centimeter long Eluvia drug-eluting stent. And then we will, in addition, perform a drug-eluting balloon angioplasty for
So this is what we did. We followed your prescription doing, I mean, the deployment of 150 centimeter Eluvia stent that was post-dilated first with a 5 mm balloon. And as you see, the stent was precisely placed at the extremity of a former balloon expandable stent. And then again, it was placed proximally, we can see it, just exactly at the stenosis. At that time, we decided to take now a Ranger balloon, a drug-eluting balloon, and we picked 6 mm by 100 centimeter. Then again, we followed your prescription, what was to apply that stent from the tip of the last stent till the mid part during 3 minutes. Could you comment on that time?
Well, what we learned from plain balloon angioplasty basically is that longer balloon inflation times do reduce acute dissection, the percentage of dissections, and as well the severity of dissections. And that's the reason why we inflate every kind of balloon for at least 3 minutes. It's not only for the drug-eluting balloon, it's even a bare balloon, if we decide to stay with bare balloon only. So it's not the drug release which is improved with the 3 minutes, it's simply to improve the acute balloon angioplasty result.
So what we did after is applying this balloon, the 6 millimeter balloon, all along the Eluvia stent. You see the result again, precisely showing that there is no residual stenosis. And we did a final assessment showing excellent result all along the SFA with the Eluvia stent, the former stent, and we see that everything was okay. Gentlemen, thank you for your lessons.
Thank you.